Chiropractic care and the risk of lumbar disc herniation. Consider two questions. What if a patient has a lumbar disc herniation but has no radiation of pain? Is there any risk of using manipulation in the treatment of this patient? What if a low back pain patient is manipulated and then develops radiation into the leg, goes to the emergency department, and is found to have a disc herniation? Did you cause this? And can you defend yourself if you are accused? Many chiropractors have and will find themselves in these scenarios. This begs several questions. Can you always know when someone has a disc herniation? Do chiropractors cause disc herniation with manipulation? Is there any evidence that manipulation is a safe and/or effective management approach for lumbar disc herniation? And what are national recommendations regarding manipulation and lumbar disc herniation? Let's start with the question regarding cause and effect. Does manipulation cause lumbar disc herniation? Well, like VBA stroke, chiropractors are accused and legally pursued when patients are found to have a lumbar disc herniation after manipulation. But like VBA, the question is an early disc presentation disguised as mechanical low back pain in a prodromal, meaning non-radicular stage, with no radiation? For VBA, as you may recall, a monumental study by Cassidy et al. In 2008 and a recreation of that study design for the U.S. in 2015 both demonstrated that patients with dissection of the vertebral artery present to either a chiropractor or MD with headache or neck pain. The progression to stroke, then, is coincidental, leading to an assumed cause and effect relationship. So is this true for lumbar disc herniation? The publication we will review tries to answer that question using the same approach as the Cassidy et al. Study. The title is Chiropractic Care and Risk for Acute Lumbar Disc Herniation, a population-based, self-controlled case series study published in the European Spine Journal in 2017. Consider this. If chiropractic treatment occurs before a lumbar disc herniation progresses to radiculopathy or neurologic deficit, and then radiculopathy occurs subsequent to manipulation, the treatment can be mistakenly blamed for causing the lumbar disc herniation. This is referred to as protopathic bias. So is manipulation the cause, or is it selective coincidence? Given that lumbar disc herniation can initially present as low back pain alone, it is possible that patients seek chiropractic or medical care in the prodromal phase of lumbar disc herniation when there is no radiculopathy. Let's get to the objective of this new study. The objective was to investigate and compare the associations between both chiropractic and PCP care and emergency room visits diagnosed as acute lumbar disc herniation using the self-controlled case series method and population-based healthcare data from Ontario, Canada. The study included all Ontario residents aged 18 years or older who were covered by the Provincial Universal Healthcare System between April 1992 and November 2004. So who were the participants? They were patients with acute lumbar disc herniation with early surgery, identified using the population-based healthcare data from Ontario, Canada, totaling over 100 million person-years of observation. So how did they go about defining the cases to be studied? They identified cases of incident lumbar disc herniation surgery between April 1994 and November 2004 who had at least 2 years of healthcare coverage prior to their surgeries so that exposure visits to chiropractors and PCPs could be extracted. These were identified using at least one disc surgery intervention code and one lumbar disc herniation diagnosis code. For those cases who presented to a hospital emergency department, the researchers identified those with lumbar disc herniation within 8 weeks prior to their lumbar disc herniation surgery. The 8-week emergency department visit window prior to lumbar disc herniation surgery was chosen in consultation with a spine surgeon expert and evidence. This means that the sequence of lumbar disc herniation leading to an ED visit and then surgery would capture any acute lumbar disc herniation related to a chiropractic visit. The observation time was divided into risk periods and a baseline. In the year prior to the index acute lumbar disc herniation ED visit, researchers ran analysis for risk periods of 4 different lengths 2 days, 7 days, 14 days, and 28 days after a visit. The baseline period was the remaining unexposed time. There were 36,745 persons identified with incident disc surgery. However, there were a number of exclusions which resulted in the elimination of most. For example, 25,323 had no ED lumbar disc herniation visit within 8 weeks prior to their LDH surgery date, and 1,048 had a prevalent lumbar disc herniation associated diagnosis or intervention within 21 months prior to the acute LDH event index date, so that only 195 cases of acute lumbar disc herniation requiring an emergency department visit and early surgery remained. Of the 195 cases, 37% had visited a chiropractor during the observation period starting 12 months prior to their event index date, and 95% had visited a PCP. So that tells us little given the long capture period. Let's focus down. 22% of cases had a chiropractic visit within 14 days prior to the event index date, while 59% of cases had a PCP visit. For patients experiencing an acute lumbar disc herniation with early surgery event, during the risk period 0 to 7 days after a chiropractic visit, the adjusted risk ratio for this exposed period was 12.9. For the exposed 0 to 7 days after a PCP visit, 87 persons experienced an acute lumbar disc herniation event, resulting in a risk ratio of 14.5. It is important to realize some potential limitations, such as contributing and confounding factors. For example, it's reasonable to assume that a PCP visit could have resulted in exposure to a number of potential treatments, such as medication, bed rest, physical therapy, and exercise. It's also possible that chiropractic visits may have also involved other therapeutic modalities besides spinal manipulation, including exercise, modified activities, and non-prescription medication. Other limiting factors are we don't know whether manipulation was applied at the incident chiropractic visit or if manipulation was applied, what type. We can assume, though, that manipulation was not part of the PCP encounter. There is evidence from randomized clinical trials showing benefit of spinal manipulation for the management of lumbar disc herniation with radiculopathy. So before we explore the evidence regarding chiropractic management of lumbar disc herniation, as a comparison, what is the natural history for acute disc herniation patients? It's normally quite favorable. 36% report major improvement after 2 weeks, and 73% have resolution of their leg pain by 12 weeks. Recently, there are 2 prospective studies that address the effectiveness of HVLA for lumbar disc herniation. Here's the first, published in JMPT in 2013, entitled Symptomatic Magnetic Resonance Imaging Confirmed Lumbar Disc Herniation Patients. In comparing SMT to injection, the results were that for the SMT patients, 76.5% reported being much better or better. For the injection patients, 62.7% reported feeling much better or better. Results for the numerical pain scale were that both treatment groups had significant decreases in their NRS scores at 1 month, 60% reduction for the SMT patients and 53% reduction for the injection patients. Here's the second study, which was an extension of the previous study. It was published in 2014 in JMPT and is entitled Outcomes of Acute and Chronic Patients with Magnetic Resonance Imaging Confirmed Symptomatic Lumbar Disc Herniations Receiving High-Velocity, Low-Amplitude Spinal Manipulative Therapy, a prospective observational cohort study with a 1-year follow-up. So here are the results. After 2 weeks, 70% had improved. By 4 weeks, 80% had improved, and by 12 weeks, 90% had improved. And recall that a study published in 2010 compared manipulation to microdiscectomy. In summary, the results were that 60% of patients failing medical management for lumbar disc herniation-related sciatica demonstrated some benefit with side posture manipulation equal to those who underwent microdiscectomy. Patients who failed to benefit from side posture manipulation received benefit from subsequent surgical management. However, those patients failing to receive benefit from surgery did not benefit from subsequent management with manipulation. And there is evidence of non-manipulative conservative care effectiveness for lumbar disc herniation. Here's one systematic review entitled The Efficacy of Systematic Active Conservative Treatment for Patients with Severe Sciatica, a single-blind, randomized clinical controlled trial. In this patient population, 65% had 3 or 4 positive nerve root compression signs. Most patients in this study would be considered by many medical physicians as surgical candidates. However, only 3% had symptoms so severe that they were referred. At the end of the treatment period, 89% of patients reported being better or much better, and at 1-year follow-up, this increased to 91% of patients, surpassing the results indicated in the literature for surgical interventions. And here's another RCT published in Spine in 2011. This comparative study between McKenzie and manipulation demonstrated similar benefit for either technique approach. So where is the medical profession regarding their attitude and concern about the risk of manipulation and lumbar disc herniation? We'll consider the North American Spine Society recommendations for the use of manipulation with acute disc herniations. Published in the Spine Journal, it's entitled An Evidence-Based Clinical Guideline for the Diagnosis and Treatment of Lumbar Disc Herniation with Radiculopathy. Specifically answering the North American Spine Society question, what is the role of spinal manipulation in the treatment of lumbar disc herniation with radiculopathy? The guidelines suggest that spinal manipulation is an option for symptomatic relief in patients with lumbar disc herniation with radiculopathy. So time to summarize. In answering our opening questions, it appears from the most recent study that similar to VBA stroke, patients with lumbar disc herniation present to either a chiropractor or PCP because of back pain that apparently has not progressed to a radiculopathy, and that subsequent to that visit, some individuals present to the emergency department and have early surgery. Given MDs don't routinely use manipulation, the implication is that this is simply an example of protopathic bias, an association that is misinterpreted as cause and effect because the patient already has the lumbar disc herniation, but it's not evident to the clinician. Regarding effectiveness, although there are only a small number of high-quality RCTs, recent prospective studies have indicated that high-velocity, low-amplitude management is both safe and effective, and additionally, other non-surgical approaches have been shown to be more effective than natural history. The evidence has risen to a threshold level of significance for groups such as the North American Spine Society, so that manipulation is listed as an option for radicular low back pain. Although we may never know in any given individual case whether manipulation caused a lumbar disc herniation, the evidence from this new study suggests an association and not a cause and effect in most cases. It appears from the literature that chiropractors can safely and effectively manage lumbar disc herniation using either high-velocity, low-amplitude adjusting or other conservative approaches.